all the speakers have elaborately explained our today's topic for CA esophagus, forming a good basis for anatomically and supported by imaging and endoscopically also. Now the podium is open and we can take any questions from the audience.
So this is a forum of surgeons predominantly. So I'd like to ask the surgeons, like, what is your preference and when do you prefer endoscopic ultrasound in your management of your esophageal cancers?
As surgeons, I think most of the time what we see are locally advanced carcinoma esophagus. So unless once in a while we come across a patient where it appears to be T1, T2, and you are seriously considering endoscopic resection, then only we are doing endoscopic ultrasound. Otherwise, in majority of cases, we don't find the need or usefulness of EUS in locally advanced cancers.
You have to understand the spectrum with which you work. In a standalone cancer center like where Professor Pratap Reddy and I work, Indian esophageal cancer or symptomatic esophageal cancer is never going to go to endoscopic ultrasound, because patient has dysphagia, you will rarely find anything like this. Patient goes for other symptoms, then you will find something like this, and this happens in multi-specialty hospitals like the Yashoda group of hospitals or standalone gastroenterology units. So in a cancer center, you will rarely actually see anything like this. It would definitely have a role for a patient who is undergoing screening or comes for an opportunistic checkup and things like that. Or you try to diagnose something else and then see these patients. So on an everyday basis, the role is definitely there, but a role is not in huge numbers. The rest of the imaging, I think nothing much to discuss. They really help you to diagnose well, and if there is a small lesion, as you said, you resect up front so that you don't biopsy and produce problems for yourself and the patient. In our hospital, it is not too often done. In GI centers, yes. Rajneesh?
Yeah, sorry to disappoint you guys, but I think the role I find in my setup peculiar to very different from what you have described. I think endoscopists are more tuned to endoscopic resections, and those see more niche areas, more glamorous areas. Unfortunately, as senior surgeons have pointed out, we don't have those patients. We don't get those patients. But there are specific scenarios where I find both endoscopic guided, EUS guided FNACs and EBUS guided FNACs to be very useful. And these are specific to Indian scenario again. So patient gets neoadjuvant therapy. They were dominant lymph nodes earlier. Now the PET shows there are equivocal. We don't know they are there or not. Patient gets neoadjuvant therapy. Another scenario, disappears for 6 months, comes back. You get a PET, you get a lymph node which is equivocal again. So in at least my center, those scenarios go to the endoscopist for a EUS or to the pulmonologist for a EBUS guided FNAC, and then to take a surgical decision what to do about those patients. Those are not really described in the textbooks the way you want the answers to be. So I think that's about all. Thanks.
Japanese, they have that classification maybe because they have more screening programs going there than in our settings. That is one situation, maybe why we are missing. And early mucosal lesions or early lesions where patient having symptoms, very less to come to a clinician unless they have dysphagia, and by the time it will be T3 stage.
Yes, sir. We agree that like gastroenterologist perspective is also changing. Like for an endoscopy, we go in often for dyspepsia, and people used to see only for any ulcer lesion or any esophagitis. But now, because the perspective is changing now people have started using this image-enhanced endoscopy often. So we are going to detect abnormal areas, and I think with this technology and with more awareness, and even like surgeons should ask the endoscopist to do this image-enhanced endoscopy, we can detect lesions early, and we can help the patients. So any patient with any subtle abnormalities, we do image enhanced endoscopy, sir. And in all Barrett's, we do image enhanced endoscopy.
The question to the gastroenterologist, what is the average time to perform upper GI endoscopy?
So the question is from my senior colleague only. So we take nearly 5 to 7 minutes, and image enhanced endoscopy can take 2 more minutes.
Okay, good point. So on what basis can you say it's total 9 minutes?
And doesn't cost more, I suppose, isn't it?
That's very good point actually. For the BSG point of view, you have to perform the upper GI endoscopy for 12 minutes. So your entry point is different from actually looking at the dysplasia. Number of times you go on inside, you have all the saliva there. You need to wash out, give the time, and then use the image enhancing. Without actually washing out, doing that, it's of no good. If you perform an endoscopy within 12 minutes, according to the BSG guidelines, on any platform that is used in UK, you will be audited and you will be asked if they get dysplasia within the next 5 years. You'll be questioned.
Yeah, Japanese have a similar guidelines, very good guidelines, and we need to document all the points, like especially incisura, and every area has to be imaged on endoscopy so that to ensure that we are not missing anything. And now we have AI, where any endoscopist is undergoes surveillance and audited by the AI. And I think this AI integration into the endoscopy will be improving the detection rates definitely.